Hi, I'm very happy to present a friend coming from the neighbor country Spain, Dr. Luis Cuadrado. Dr. Cuadrado has been developing some new features and protocol around digital dentistry and will bring back to this Congress a very modern thematic in this field of aesthetic dentistry. Luis is a plastic, reconstructive and aesthetic dentist with a private practice in Madrid, where he also develops a dedicated training center. He's also the director of the postgraduate training program in implantology at UDIMA University in Madrid and a member of several scientific societies such as EAO and ITI. Dr. Cuadrado has more than 100 scientific articles published, and his practice focuses in oral implantology, extraoral and reconstructive surgery. He is also a member of the World Advisory Board of 3Shape. Luis will be sharing his knowledge about the digital workflow in implantology with the subject, a new implant dentistry. High quality, same day, immediate loading from an intraoral scanner. I'm sure you'll be overwhelmed by this presentation. See you in a couple of hours.
Hello, dear colleagues and friends. First of all, let me give you a warm welcome to my lecture in this 2017 International Aesthetic Masters. It's an awesome project from Dr. João Borges, my friend in Lisbon. So I want to congratulate you and all your team for this awesome project. And also I will, of course, thank you for allowing me to be here lecturing worldwide in this project. My lecture is regarding new implant dentistry. From my side is high quality same-day immediate loading from Intraoral Scanner. It means that we are going to provide our patients with provisional prosthesis same-day in a full digital environment from Intraoral Scanner. First of all, let me introduce myself. My name is Luis Cuadrado. I am a medical doctor. Also, I am a specialist in plastic reconstructive surgery, medicine, and also odontology. I live in Madrid. We are in this center, IDOS Implantología, which is a learning center and also a clinical center. So we are located in Madrid. Madrid is the capital city of Spain. This is the upper part of the clinical part, in fact, of our installations. So we have a full digital approach to our patients, in not only in implant, but also in aesthetic dentistry, in a chair-safe model, and prosthetics, and also, of course, in ortho. The lower part of our installation is devoted to learning. We have a lot of courses here in implants, in prosthetics, and ortho, everything, So those are our facilities. As I was telling you, we are in Madrid, in the capital city of Spain. We are located downtown, and I will fully encourage you to visit Madrid, to visit Spain, and to have nice days with us in this awesome country. Okay, let me talk something about we are going to talk today. It's about digital implantology in a full digital environment. When you are dealing with implants, you have two different approaches. The first approach will be to place your implants in a conventional way, just placing your implants. Then you place your scan bodies on your implants, take your digital impressions intraoral with the intraoral scanner, and then with the CAD/CAM software, your lab is going to design the provisional crown or the provisional bridge for your patient. It means that you are going to provide your patient most of the times with a temporary to be placed same day, from 1 hour to same day to 4 hours later, a provisional, a PMMA prosthesis to the implant from a crown, as I'm telling you, from a crown to a full arch. It means that we are making a temporary, and our goal, our aim is to provide the patient with as many temporaries as we need to reach the final model temporary prosthesis. It means we are going to copy that final temporary bridge in the final framework, in the final prosthesis to be placed in our patient. So it's a full digital environment where we are going to place our implants in a classical way, taking our impressions with the digital intraoral scanner, then a CAD/CAM software on the lab, then made our temporary and reach our final temporary to be copied in the final prosthesis. The other approach, of course, is guided surgery. In guided surgery, we are starting with the intraoral scanner scan of our patients, also a CBCT. We are going to merge both files on a guided surgery software. We are using Implant Studio from FreeShape. Inside that software, we are going to plan the position of our implants as usual, in terms of we are going to take into account some kinds of bone availability, the anatomical facts, and so on. And also, we are going to design inside Implant Studio, make a pre-design of a provisional prosthesis. Okay. So that file from Implant Studio, we are going to send that file to our lab, where they are going to receive all our planning. They will be printing our guide for guided surgery, and they have the file to design the provisional prosthesis. So they are going to make all the emergency profile of our patients, of our implants in our patients, just planned, and made the provisional temporary prosthesis. We call that guided prosthetics. Why? Because the most important thing is not for my side. It's not only to place your implants guided, but the ability to have your previously made prosthesis fully made with T-bases on it, and just at the end of the guided implant placement, just take from the surgical table your guided prosthetics and place it right on your implants recently places. So the question is that at this time, if you are able to do that, we are in both approaches. We are in the same situation. We are in having a temporary in our patient. So we will also construct as many temporaries as we need to reach the final temporary to be copied on the final prosthesis. So two different approaches. Both are full digital with the intraoral scanner. The main difference is that in the first one we are scanning our implants, and in the second approach, which is guided prosthetics with Implant Studio, we are having our CBCT, we are having our intraoral scanner, and then reach to the temporary. And both in common, the same way, are to reach the final temporary bridge to be placed in our patient. So what is our approach? You have to take you have to consider that what I'm going to show you today is what we are doing in a daily basis in our clinic. So I frankly think that things has to be simple, things has to be done in a correct way to make it simple, to make it available for all doctors worldwide. So What are the different steps or the different elements in our treatments? First of all was to select an adequate implant for our treatment, then special surgical technique. You will note how this is special. Then we need to have some kind of confirmation that we are going to be able to make immediate loading. Of course, the use of an intraoral scanner. And the way we scan, the scanning protocol is sometimes different, even from the recommended from the intraoral scanner manufacturer. You have to scan in a different way. You have to take into account when you are dealing with the case. Sometimes are somebody call them big cases. So finally, the construction, the production of temporaries. And finally, we are going to copy all our temporary, the final temporary in the final prosthesis. We are going to make an assessment of the passive fit with the clear bar and the Sheffield text. So we are going to go on all those steps to clarify. First of all, the implant. Of course, we need an implant that allow us to make immediate loading. It means that it has to have a lot of control in terms of bone contact, also self-tapping implant, and also designed to be placed on cortical bone. So we are using usually bone level taper, the new implant from Straumann, and with different surfaces, you know. And we are really happy because it allows us to make immediate loading. I will say that maybe 80% of our cases. Of course, there are another implants you can use, but we are usually the most of the cases you are going to see today are done with bone level taper from Straumann. The surgical technique is important because you have to have some things, different things in consideration. Okay, so it's not only to place implants, but we need to get from the implant the ability to make the medial loading. So we are going to make a progressive drilling. It means that most of the times we are under preparing our implants, allowing high insertion torque with our motor and also by hand. We are trying to use longer and wider implants. The much longer and the much wider, you will have a lot of bone contact with your implant, a lot of implant stability. Some of the times, or I will say that most of the times, you need to go flapless. Why? Because as you know, the intraoral scanner is going to register all the information inside the mouth. It means that if you are dealing with a case of, imagine a lower maxilla with a high floor of the mouth, and you are making a big flap, of course, sometimes it's needed for you to do that. But if you are making a flap, and then you are going to place your implants, place your scan bodies and scan, the floor of the mouth is always moving. So as less movement, the less movement you have, the best result in your scanning, and it is much more favorable for your final file. We are going to use suspensory sutures. It means that we are going to fix you. I will show you a case right now. You are going to fix the soft tissues on the bone in order to avoid this mobility from the flaps when you are doing flaps. And one important thing, of course, as usual, is to have a visual control of the abutment fitting and the scan body fitting onto the abutment to be sure that everything is correct, you know. So progressive drilling, longer and wider implants, to go most of the time flapless, usually in the upper maxilla. It means that you have to have a correct study of your patients. You have to plan your surgery with CBCT. You have your even to make guided, non-guided implant placement, but guided drilling of your implants with the guided surgery softwares, suspensory sutures, and visual control of abutments and scan body fit. This is a case, for example, this is a pro-arch in the mandible, and you need to take control of all the things that can interfere with your result. For example, in the upper left corner, that's the device to guide the removal of the cortical bone surrounding the neck of the implant. Then you are going to place your abutments onto the implants to have a visual control. Of course, you have here a big flap, some big flaps, and please note on the lower right corner of your screen how we placed our scan bodies. Please note that all the flat part of the scan bodies are located to vestibular. This is an upper view, a coronal view. So all the flat parts of our scan bodies are directing to vestibular, because we try to have all the flat parts of our implants, the one to be used by the dental technician in the best fit of our scan bodies onto the implants to the same side. This is correct, because with our first scanning, we are going to register all those flat parts in the same file. And of course, you can also note how we made a hole in the mandible, and we are giving a transverse suture, fixing the floor of the mouth and the vestibular flap to the bone. So it makes it reaches immobile, and no soft tissue is moving around your implants. Your scanner is going to register it perfectly from both sides, from the vestibular and from the lingual part. If you are avoiding if you do not do that, if you avoid to make this suture, so tissues in the floor of the mouth are moving with the tongue, so they will almost cover your implants, and of course you will not be able to register your lower scan in a correct way. So I fully recommend to make this stitch to the bone from the lingual and from the vestibular flap. Also, it gives your patient a much more comfortable post-operative situation, and less swelling and less pain, because all the tissues are stable, are immobile. Okay, so please note that we are talking about a digital approach to implantology, but all those steps are important in the final result. It means that digital and big cases are not only a question of just scan or just to place your implants, but you have to make your preparation of your implants in the correct way. You have to place your scan bodies in the correct way. You have to place your abutments, and also you have to take to be the flaplets, or to take care of the immobilization of your flaps, to get the final file from the intraoral scanner in a correct way. Okay, so we need to have an objective method to be sure that, or to try to be sure that our implants could be loaded same day. The only one we are using is the ISQ value with the Ostel, and there are a lot of publications confirming this, and we are using it on a daily basis. And of course, it's not only a tool useful in this kind of approaches, but we can monitorize during the whole presence of the implants in our patient to the final prosthesis sorry, how the implant stability, the bone to implant contact is improving or not, and take any kind of measures to correct or to affirm this. Okay, So STEL for us is one step more in our treatment, the recording of the ISQ value. From the point of learning and everything, it's an excellent device because you can compare what are your results with the software from STEL. You can compare what are your results on a long term inside different implant companies, implant lengths, diameters, and everything. So it gives you a scientific, we could say, it gives you a scientific idea of what you are doing based on an objective method of evaluation of your work. Okay. Let's go now to one of the most important things, which is the intraoral scanner. There are a lot of intraoral scanners out there in the market. We are using from, I would say, 5 years ago, 6 years ago, the Trios, which is an intraoral scanner from 3Shape, and we are really happy with it. The question is that intraoral scanner has evolved a lot, and with Trios you can do everything. It's a non-powder non-powder intraoral scanner. That's very important because you cannot use an intraoral scanner with powder for surgeries with the flap open. So it gives you a lot of satisfaction and a high accuracy in all your applications. It means that from single unit to full arch, not only in immediate loading but also for the final prosthesis. We are doing everything digital in the clinic, almost everything. Okay, so the intraoral scanner opens a new, let's say, two new ways of dental treatment. The one in the upper is the chair-safe model, where you are going to scan your patient, and then the file is sending to your software, and you can produce in your clinic in a chair-safe model crowns, inlays, onlays, single units for implants, provisionals, and even final prosthesis. Okay, that would be one approach. And the second approach is that I scan my patient and I send my file through internet to the lab, where a skilled dental technician is using Dental System or any other software, which is the software for designing the prosthesis. So big cases are usually done on this second approach because of course you need a dental technician by your side. Even my personal experience is that this is an excellent approach of work from the intraoral scanner for you. Okay, so what are the main facts? The main fact is that, please note this, there are a lot of articles out there. This is one from the Journal of Indian Prosthodontic Society in 2014 from Dr. Buthayan, and this is a review of all the situations that can cause some kind of, let's say, inaccuracy in our treatments coming from a conventional impression. It doesn't matter if it's silicone or polyether or whatever you want. There are a lot of things, as you know. For example, the position of your implants, the material you are taking your impression, the material you are pouring your model, the skills of you taking that impression in your dental lab, having that master classification. All the situations regarding stability of materials, stability of models, even the fitting between the parts you are using to take your impression, if they are original or not, a lot of things that cause that we are usually working in the conventional world with 50 to 70 microns of inaccuracy, and most of us, we are happy with that inaccuracy coming from different situations we cannot avoid. But the question is that when you are dealing with the intraoral scanner, for example, this is an old publication. In fact, it is from 2015. It means that this has nothing to say right now, because all the devices, all the intraoral scanners in that publication, in that advertisement, are discontinued. So, but at this time, and the most important conclusion is that even the worst, with the worst results in this comparative, in this article, it's 45.2 in terms of accuracy, and 26.4 in terms of precision, far than the 50 to 70 microns. It means, and to be clear, that even in 2015, intraoral scanner gives you more accuracy and more consistency than a conventional impression. The question is that of course, today all that accuracy and all that consistency is better, it's higher, and the question is that we need to scan our patient, to use the intraoral scanner in the correct way to get the results we need, because we are not going to invest in an intraoral scanner if that intraoral scanner do not allow me to make everything in my clinic, from ortho to aesthetics to single units to full arch, everything. I need a machine that helps me. Even the concept, the real concept, is that intraoral scanners are starting a new dentistry. So the question is that the hardware out there, the intraoral scanners, are enough, most of them, to get excellent results. But the question is that you need to know how to use that intraoral scanners to get the correct file. And you have to take into account all the points we are talking before to get the good result. There are things for intraoral scanner that doesn't matter and almost impossible in the conventional world. For example, when you have implants too deep placed in your patients, or with a great angulations between them, the material the conventional material, the polyester or the silicone, when you are taking your impressions, can be deformed because the position of your implants. But the intraoral scanner, it doesn't matter if they are deeper, they are with different angulations. Just the intraoral scanner is going to take pictures of your intraoral situation. It doesn't matter what is in your patient mouth. But you have to take into account that all the implant companies are now dealing with this new dentistry. That means to provide our patients with immediate value. If you are going, of course, our advice will be to use always abutments in our patients, multi-unit abutments, REA abutments, to even to be able to correct the angulation between implants using angle abutments, and to make things simple and stable, not to take out the prosthesis from the implants. But some of you could think to go direct to implant with a T-base, direct to implant. The question is that even in the best situation, T-bases are out there can have some kind of problems when you are dealing with implants that are with the divergence up to any degrees. It depends on the implant system you are using. For example, you have here the Vario base from Straumann. It's an excellent T-base for bridges, but even with the best registration, it doesn't matter if it's conventional with silicone or polyester, or if it is digital. If your implants has up to more than 30 degrees of divergence between them, your provisional prosthesis is not going to fit. But this is a problem not related to accuracy of both words. It's just a problem of geometry of the tip bases. So most of the companies are redesigning the connection of the tip bases when they are going direct to implant, to try to accommodate to the new models of digital dentistry, allowing in fact making shorter that part which is going to enter inside the implant connection. Okay. Let's talk about scanning. There are some things very important. We call it one shot. What means one shot? One shot is one shot scanning is when you are starting your scanning, you start in the, imagine, the lower mandible. So you are going to start your scanning of your patient, okay? And you have to do it one shot. One shot means that you never stop scanning until you get a main body of your file. It means that you have to stitch all your image without stopping the scanner. Why? Because if you stop the scanner, that's a different stream of your scanning, and when you are starting your scanner, both streams could not be stitched in the correct way by the software. So first of all, you have to make a one-shot scanning, non-stopping scanning, to create and to register all the most geometrical structures in your patient mouth without stopping, in order to create a main scanning body. And then up to onto this main scanning body, you can make different adjustment scan with your scanning, because the most important thing again is the stitching. It is the stitching process when you are scanning our patient. That's the number one and number two approaches to scanning. The one shot and create main body is they are all important, of course, and that's the reason, because we try to orient our scan bodies to the same side. It means that you have to place your flat part of your scan bodies to vestibular, to lingual, but not one to vestibular, the other one to lingual, one to vestibular, the other one to lingual, because otherwise you are going to have a tough scanning of your patient. So most of the times you have to remember that with the magic with digital dentistry is that when you are taking a conventional impression, you need to take a perfect conventional impression to create your master model. Okay, with digital impressions, you just need to register some part of the scan bodies to create, let's say, to be able to design and construct to be able to design and construct the temporary prosthesis, because you are working at this step, you are working model free. You just need to make the best fit of your scan bodies with the implant digital replica in your CAD software to be able to design your prosthesis. So it's a complete different world. So as many times as you try to orient your scan body flat parts to the vestibular, all of them, or to lingual, that will be very helpful in your work. And of course, you have to have a protocol for scanning. We usually start in lingual, then go to the occlusal, and then go to vestibular, and then make minor adjustments. If you are able to create the main body scan, you will get nice, excellent, and fully accurate files for full arch with the Trios 3 from 3 shape. Okay, let me show you this video. This is a real patient, of course. He was referred by his perio. All those discs has to be removed, and what you are watching on the right side are two different scans we make in the same patient. On the right side, it's a regular scan. Of course, we did the first visit of this patient. We make a study model scan. The study model scan is a scan of how the patient is with the actual situation of the patient, and then you have two ways to work. When you just remove your teeth, place your implants, place your scan bodies, and then you can erase. That's the left window. You can erase only the part where you have placed your implants, or you can erase the whole upper maxilla scan. So The window on the right is where we erase the whole upper maxilla scan, so you can notice that there is a big difference in terms of images, in terms of length of time. We need to register the digital impression. In fact, on the left window, we are trying to get the file, and on the right window, we are finishing our scanning of the patient. Why? Because on the left window, we erase only a part of the study model scan of the upper maxilla, only the part where we were going to place our implants. Now there are implants, there are stitches over there, there are some kind of sutures, scan bodies, everything. And the intraoral scanner needs to stitch the new image with the image from the study model, and that is very tough for the scanner, and you can have not an accurate file. So our advice will be to use the right window approach. It means that to make a study model of our patient, and then make a copy of that study model, a digital copy on the computer, on the Trios, and then just erase the jaw or the maxilla where you are walking. This is on the right, it's finished, and just erase the whole scan, the whole scan of the maxilla, and not erase a part of the scan, because sometimes it can be really difficult to make a correct scan of our patient. So this is the scan on our system. We always take out the color information and then go to the black and white information, the geometrical information, which is the one we are taking into account to be sure we have a correct scan. And now we are going to send it to our lab. This is our lab. And because we have this is the design of the temporary bridge for our patient on 6 implants, because we have the study model is the blue. Our lab technician can design the new prosthesis, taking into account all the information coming from the study model scan. It means that we have vertical dimension, we have occlusion, we have aesthetics, we have everything. Just we are going, she is going, or he is going, the dental technician is going to accommodate the clinical situation and the design to the clinical situation and the aesthetics of our patient. So that's those are the healing abutments in our patient, and that's the temporary bridge fitting nicely on our implants. And now we are placing our screws on the T-bases to the implants, okay, 5 newtons centimeter just to accommodate, and then go to 15 newtons centimeter in our patient. So this is a TelioCAD temporary bridge in the upper. It has been milled. The milled process could take about 2 hours, and the design process with our technique could take about, that's the nicest occlusion and interaction relationship, because the lab technician just copy the information we give them with the study model scan. Okay, so as I was telling you, this is TelioCAD. The PMMA behaves nicely with the soft tissues of our patient, and it allows us to create and to model all the soft tissues in our patient. So we are in the different steps. We have covered some of them, and we are reaching the final one, which is the temporary. The temporary for us is also not only a prosthesis, but also, of course, and I'm sure you agree with me, it's also a diagnostic tool for example, this is a guided prosthetics, temporary full arch bridge. It doesn't matter that this patient from first time in 50 years in his life has now new teeth, new fixed teeth in his mouth coming from a denture, a partial denture in this case. This is a guided prosthetics. It means that we place guided our implants in the upper maxilla, and we have this bridge previously made. Just remove the guide and just place our provisional prosthesis in place, screw our screws, and fit our prosthesis in our patient. Of course, I agree with you that this is not the perfect temporary prosthesis, but this is a diagnostic tool in terms of aesthetics, phonetics, everything. This case was made with Arturo Godoy, my friend in Mexico. He is dentist and he is an excellent dental technician. He makes nice dentogingival prosthesis, and this was the first one right after the surgery. We make, I can remember, I think that 3 more temporary bridges to reach the final model temporary bridge for our patient. We were happy with that 3rd temporary bridge to be copied on the final prosthesis, and this is the final result with Arturo of the dentogingival prosthesis with IMAX. And that's the appearance of our patients in terms of rehabilitation, in terms of happiness, even of the team. We were really happy with the results. So it means that coming from digital, you are going to make as much temporary bridges as needed to reach the final model prosthesis to be copied on the final. So for the dental technicians, this is incredible because they are using the best of both worlds, the best of digital to make things in our treatment simple and really straightforward from the patient from the very beginning, and to make things simple to use the best of digital and the best of their skills as dental technicians in terms of get those nice results. Okay, imagine we are now at the end with that model, and we take our final scan for our patient. This is an upper maxilla. So the first step is with that scan, the lab designed this clear bar to be sure that our file, the file that they are going to use in the final design of the final framework, it is correct. It means that just before, of course, to use that file to design the final framework, clinically we need to be sure that of course that file is correct. Okay, so we make that clear PMMA bar. It's a milled square bar that allow you even to see with the micro. This is the shot with the size microscope, dental microscope, how nicely the screw is entering your abutments. Okay, on the right corner, on the upper right corner, that's a ProArch framework made by Createch in Spain, which is an excellent milling center. Okay, let me tell you that after that, the lab is designing the full arch, and we are trying that framework in our patient. We use the SHEFFIELD test. This is made by FIBO, this structure, which is sinterized, and the connection is milled to be sure we have a nice setting on our implant. So we just place one screw. That's a digital model with removable gingiva. We just place different approaches. Those are different implants, external hex, internal. We just place one screw, distal screw, and take a X-ray to be sure that we have a nice passive fit. There are a lot of cases. Those are also made by FIBO, and lower That's the distal screw tightened, and this is a ProArch framework onto Straumann abutments, onto bone level taper, and we are doing the same thing. We are making our connection, screwing one screw, and taking an X-ray to be sure you have enough implant. The fitting is really passive. Okay, so those are different situations and different. That's a video we did only to show everything is possible. Okay. Okay, let's go to a first patient. This is a patient also referred by her period. All those were terminal dentition. We are going to remove that teeth. We are placing our bone level implant, taking our ISQ values. The implants, the 4 anterior implants were okay to be loaded, but the distal implants, the values were lower, so we just connect only 4 scan bodies onto those Straumann bone level taper and leave the distal part without scanning. So now we take our intraoral scanner of our intraoral scanner of our patient, take the occlusion, and that's the file is now in dental system, in the software CAD software from 3Shape, making the best fit of our implants, the digital best fit, and also the design of the full arch for this patient. In the surgery unit, we are now removing the tooth remaining. We leave those teeth in place, and once the full arch is already milled, we are able to screw to place in our patient. Now, please note the difference between the position of the gingiva, of the soft tissue, and the prosthesis at the end of the intervention. That's about 2 hours later of our provisional prosthesis. So that's the first the consultation situation of our patient, and that's the situation 3 hours after surgery with a nice conventional, with a nice full digital prosthesis in the patient. So there are dramatic change in a minimal invasive approach, fully possible in using the intraoral scanner, changing lives thanks to technology, thanks to adequate protocol. This is another patient, also with failing dentition. We need to remove all those teeth, place, in this case, is 6 bone level taper implants, place the scan bodies on those bone level taper. We are going direct to the implant level, and now the lab technician receives the file from the intraoral scanner, designs it, the provisional prosthesis in dental system, and then the final bridge, provisional bridge, is designed and milled in a milling machine from a disc of TeleoCAD. That's the provisional prosthesis, and that's the situation of the patient because we remove the remaining teeth, and now we have the full arch bridge already ready to be placed in our patient. So this is the fitting of the prosthesis in a minimal invasive approach. Now we have the TeleoCAD prosthesis, and thanks again to the excellent behavior of your PMMA with the soft tissues, you get excellent results in terms of. And please note the excellent occlusion, interarch relations in everything. We are just using all the information coming from the study model scan to the design scan in an excellent way. Again, note the excellent contacts in our patient. We just need to touch nothing. If you follow all the steps, everything is correct when you get the temporary. And this is very important because as a diagnostic tool, if you are happy with this result, your lab can copy this this design in the final in the final prosthesis. Okay, so let's go to a guided case. For me, single unit, single crowns in guided, they are really demanding and they are really difficult to get. But this is a case made with Implant Studio. This is the mirroring model, the mirroring design tool, where you can mirror the anatomy of the crown you are going to place. Even you can use virtual articulator. This is Implant Studio. This is the alignment between the files of the intraoral scanner and the file of the CBCT. And now you are placing your implants. We need to remove that 1-1 in the upper. So you are placing your implants as usual, taking into account the amount of bone. And please note this part, which is the slot we ordered a system to create in the guide. I'm going to stop just a minute. That's the slot. That's the slot you order Implant Studio to create in your guide, because we need to stop the insertion of our implants when the points of our insertion device arrives to that point. You are going to see it right now. So this is Implant Studio, the guided prosthetics software from 3Shape. We are using the trios, we are using the information from the CBCT, and we at the end we have 3 files. One file is the file of the guide itself to be printed, okay? The other file is the file of the position of the implant, where you will receive all the information in terms of the different issues with your implants, and also the pre-design of the temporary crown. Let's go back a minute. Of the temporary crown you are creating. This is the temp crown we are creating inside Implant Studio, but we do not design the emergency profile of that crown. Once we finish all the planifications, we finish everything, we send all the files. You have it here. We send it to our lab, and our lab will receive the file from the guide to be printed, and the file of the crown to be designed the emergency profile. The question is that when I'm going to make my surgery, I will have in my surgery table, I will have my guide printed, okay, and I will have also my crown with the T-base already glued on it. So if everything is correct, when I place my implant guided, I have to stop the insertion of my implant when the points reaches this slot, and at this moment the connection of my implant in the real world, in my patient's mouth, has to be in the same situation that when I did my planning. It means that I will be able to place direct the crown on my patient. So let's go to see the case. This is the case. Sorry, I'm going back. This is the case. Let's go. We were here, okay? We were here. So now we are going to the surgery. We need to remove that 1-1. Remove it. It's a failing tooth, referred by her endo. Close examination of the bed. That's the guide. That's the drills for the guided surgery system from bone level taper from Straumann. Different spoons, different heights. You know about that. That's the bone level taper. And now those are the points. The points we need to stop right at the same point where we place our slot. Now we place a cover screw on the implant and just place some bios in this case to graft the vestibular part, and that's the guided crown already made We have it in the surgical table, ready to be placed on our patient, because we reaches the same position of the implant in the reality, in the bone and in the planning. Allow me to get that excellent result, let's say 45 minutes after starting the procedure. Okay, so we have shown you this case as guided. That's the immediate result of the guided surgery of our patient. That's the T-base, the vario base from bone level, Florence Straumann, and that's the provisional crown placed in our patients. If I'm not happy with the aesthetics with that crown, I just have to call my lab to tell, please make any kind of the different design in this part or this part, you know, and you get 45 minutes later a new crown to be placed in your patient. So let's go to 4 guided surgery, guided prosthetics, single unit implants. This is Implant Studio from 3Shape, the CVCT, the pre-design of the crowns, the virtual articulator. We are going to make a clear idea of the beating of our patient. Now we are placing my implants. We have to have a lot of things in order to make this a reality in terms of position of the implants, exit of my screw. Then you send your file to dental system, where your lab is going to design, as you can see clearly in your screen, the emergency profile and the final design of your crowns. Those are the 4 vario base we are going to use. That's the 4 crowns the lab is going to mill, and that's the design of the emergency profile. Now this is the surgery we are going to remove. We have our guide and we have the 4 crowns already. That's the guide with the slots. Please note the slots here. And we have the guide, we have the crowns, the guided crowns. Now we are going to make our surgery with the guided surgery software from Straumann, from bone level taper. We are placing the second drill, and we are not using the final drill because the bone was so soft. We need to preserve as much bone as needed, as we need to get a perfect fit between the implant and the bone. We are reaching with our points the part of the guide with the slot, and we are finishing there the placement of our implants. Now the question is that doing it that way, again, we are going to use the Ostel to get a result, an idea of the capability of our implants to allow them to support the immediate loading. And then we are placing the 4 crowns. If we reaches the same position in the planning software and in the reality in the bone of our patient, you will be able to place your crowns direct in your patient. Okay, so that's first giving torque to 5 newtons per centimeter. That's the finished case with the 4 temporary crowns. Now we are going to allow to let the GAM to remodel around that design of our patient. So those are 4 crowns. Let's go ahead with this case, which is very important. This is, let me go back for a moment. This is a common situation with all those failing implants in the lower. The patient is anxious, of course, and she needs a simple and reliable solution to the problem. So this is the study model of the lower mandible with the failing implants. That's the study model of the maxilla, sorry, and the occlusion of our patient. We keep that, and now we are going to surgery. That's the lower. We are removing the bridge, removing the implants, and now we are going to remove all the implants there, and make a Friedrich of the wound. Open a flap. Let me go. We are opening a flap. We are removing all the soft and granulomatous tissue in the former implant beds. And now we are going to use the bone level taper, remodeling all that bone, placing it in the best implant position we could have to get the best bone to implant to bone contact. So we are keeping all that valuable bone from autogenous bone from our patient to be used as a grafting material at the end of the implant placement. So we are now in 4.1 preparation for a 4.1 drill, and we are going to go to the 4.8 to get as much room for our implants. Now we are placing it with high torque. We are placing the implants in all the parts we previously select from those remaining parts of our patient that has no problem with that. Please note that we did no remodeling of the bone because we are trying to get to preserve the maximum amount of bone. Now we are going to surgery. We are going to finish. We are taking the level of the ISQ, the values with the Ostel, to be sure that we can load all those implants. That's our approach. One step more. Now remember we talked about the holes in the bone where we make our sutures to fix the floor of the mouth. Those are 3 holes. Now we are placing the scan bodies with trying to orientate the flat part of the scan body to the same part. Now we are grafting all the parts around the implants, and as we have the holes in the bone, we are going to use 3 sutures to fix the floor of the mouth. That's the suture from vestibular to bone and then to lingual, to fix the floor of the mouth to the bone. So we make it almost immobile. It means that I'm going to be able to scan in a simple way to register it perfectly, and also the patient is going to be more comfortable. How you can notice how this is really important. This is the final scan. We are going to send it to the lab. Let me show you. Okay, this is the final scan of our patient. Lower, upper, lower with the scan, upper, and occlusion. Now we are going to send it to the lab because we preserve and we have the study model scan. The lab is going to use the information from the failing prosthesis of the patient to be used on the design of the new temporary full arch bridge, because while our lab is designing this prosthesis, this temporary bridge, we are removing the teeth of the remaining teeth in our patient. So that's the full arch to be placed in our patient. That's the situation. Same day, 3 hours later, it's the time to be designed, the prosthesis to be placed. Now we are placing the prosthesis, and again, if all the information we gave to our lab is correct, the prosthesis is going to fit in a nicely passive way, and also the occlusion and the interarch relationship will be perfect because they just copied all the information. That's the occlusion 3 hours after the treatment. So this is again amazing in this new world of failing implants. Okay, let me show you another case made by Arturo Godoy. I'm going to go quick around this case. This is a failing dentition in the upper, so we made guided prosthetics in the upper. So inside Implant Studio, we make a virtual extraction in the upper right corner, virtual extraction of the teeth going to be extracted, remove it, and we plan all our implants, and finally we design the guide to be printed, and also we design the full arch temporary bridge to be placed at the end of the intervention. This is the surgery. We place the 6 implants in the upper, take the ISQ values before removing the guide, making sure that everything is correct. Now we are going to remove the guide. That's the ISQ values of the different, and just remove the guide and just place the guided prosthetics full arch bridge previously made by our lab. We have in our surgical table, just before starting the surgery, we have the guide, and also we have the temporary prosthesis designed, taking into account the previous implant situation. Again, this is a diagnostic tool. We use it to design the final prosthesis. When we reach to the final prosthesis, this is the design of the different full arch zirconia framework to be veneered with IMAX made by Arturo Godoy and us here in Madrid. So we are using 8 implants, and those are that's a framework going in a full digital environment. That's Arturo placing the IMAX on top of our patient, the try-in in the upper window of the prosthesis with angle screws to avoid. That's the nice work of Arturo. Again, we are mixing the best of both worlds, digital and analogic, and the skills of a dental technician. The dental technicians are, of course, our colleagues, our friends, and one of the most important things in our work. No, that's the work, different steps with Arturo. So this is the final dentogingival prosthesis with 8 implants in a full digital approach made only with intraoral scanner, and that's in the lower right window. You can see the final aesthetic of the patient, and in the left the fitting the X-ray of the final framework of the final prosthesis in our patient. Again, this prosthesis was made with zirconia framework, IMAX on top. That's the fitting of the prosthesis in our patient. Just fit, screwing the 8 and giving torque, 8 bone level implants, and a nice result. That's the fitting and the passive fit of all the T-bases to the implants in our patient. No? So we are really happy with this result. We did a lot of cases. We have a lot of cases of full arch cases. That's the final appearance in the X-ray of the excellent fitting in a full digital environment, only with intraoral scanner, bone level and 3C. And this is our final case I want to share with you. It's a bimaxillary case in a mild atrophy patient. We just place 4 implants in the lower in a pro-arch environment, in a pro-arch treatment. This is the case I showed you before. That's the in the upper we place also 4 implants. Those are the scan bodies. Then we have our intraoral scanner, both the upper and the lower, using the same approach I showed you before. And this is the lab technician designing in the lab the lower and the upper prosthesis. The upper is going direct to implant. We are placing it 3 hours later of our finishing of the surgery. We are placing the prosthesis in the upper and in the lower. The lower is going with ProArch S-Ria abutment, and we are placing the screws in the prosthesis. So those are coming from the removable complete prosthesis, full art, the full prosthesis, the complete the patient has, and those were a copy of that. That's the amazing fitting of the passive fit of all the components of this previous prosthesis. Okay, again, this is a diagnostic tool. We are going to make as many temporaries as needed. This case was made also with Arturo Godoy in Mexico, and we had a collaboration in the distance in terms of designing with our lab. Our lab was talking with him and with all the using all the amazing situations that allow the technology. For example, they can make some kind of design there to be produced here in our lab, or they can make even enter the computer here in Madrid to design and to get the final result. When we are reaching the final, we are going to make with that former file a new scan, 2 clear bars to be sure that's correct. And with that, those clear bars, we are going to take an X-ray and then take some kind of registration between both in terms of middle line, in terms of occlusion, everything, to get a conventional idea of where we are in terms of aesthetics of the patient and everything. So we are mixing both worlds because with the impression from the digital impression from the trios, from the intraoral scanner, we are going to be able to print full digital models. Okay, so we made a setup of teeth on those clear bar to be to have an idea of the aesthetics of the patient and occlusion. That's suggested only. Even we can make an intraoral scan of this prosthesis for the lab to have an idea of where they are, where they have to reach with the final design. So this is the trying of the prosthesis. Okay. So we make any kind of modification on this, take the final scan, and for the final scan we make a new clear bar, confirmation bar to be placed to the implants, to the implant level in the upper, to be sure everything is passive, and to the that's the upper with a nice fitting of all the screws. With that information, we made a new provisional coming to the final model temporary bridge to be copied in the final. And that's the lower temporary prosthesis, a new one, upper and lower, to know where we are, to make any kind of corrections in terms of occlusion, aesthetics, everything. When we reach the final one, we just have to copy all the information in the final prosthesis. We made both frameworks. Those were made by Createch. In the lower, it was going to be a hybrid prosthesis with acrylic teeth. In the upper would be ceramic. So we are trying the frameworks in the upper, in the lower, that's the lower, placing the screws to be sure everything is passive, everything is correct. Take an X-ray to be sure that everything is correct. And now we are happy. We just need, the lab only is going to copy the information of the provisional into the final. Those are the final prostheses made by our lab with Arturo Godoy. Those are digital models from the intraoral scanner impressions, and that's the upper, that's the lower, hybrid prosthesis in the resin teeth in the lower, ceramics in the upper. and just place it in your patient. If everything is correct, it's going to fit perfectly. That's a dentogingival prosthesis going to fit perfectly in the upper, in the lower, occlusion, everything. So the usual situation is that you don't need to make any minor adjustment to your prosthesis because everything is excellent. That's the final result of our patient in terms of fitting of the final prosthesis, final frameworks, and that's the situation and the dramatic change of our patient. It was made by our lab here in Madrid, and Arturo Godoy, who was the dental technician that collaborates here in Madrid with our labs to get this result. So this is the final aspect of our patient, the final aesthetics, and we all, the dental team, of course, we are very happy. So I can say you as a summary, because I think this is the last slide. I would like to say you as a summary that a new dentistry, a new implant dentistry is coming, based on immediate loading on your cases, providing the patient with same-day prosthesis to be copied on the final prosthesis after new prosthesis has been made during all the treatment of your patient. Full arch are really possible. We are doing it on a daily basis, based on different steps in the whole treatment. To get a good file for the final full arch, you have to start from the very beginning, from the day you are placing your implants, even selecting your implants, the anatomy of your patient, the complete study, using guided surgery software, everything that technology and implants give us today. So thank you again. Thank you, Joao, for allowing me to share with all of you these amazing moments. This is an awesome project, the International Aesthetic Masters, and I can be more proud for you to allowing me to be here. That's my email, that's my contact, and the contact from IDOS Implantología, where we were really happy to see you. Thank you so much for this opportunity, and I hope you can get from this lecture some kind of ideas that will be useful on your daily practice. Thank you so much. Bye. Thank you.